Hello, everybody. I'm Julie. I'm from the Foundation for Sarcoidosis Research. We are going to get started in just a few seconds, but we're going to, let people kind of join us here as they can. Okay, well, we'll go ahead and get started. Like I said, I'm Julie with the Foundation for Sarcoidosis Research. Hopefully everyone is able to hear me okay. We have all of the phone lines on mute, and we are recording this webinar, so if you want to go back to anything and listen to it again, hopefully we are successfully recording it, and we will have it up on our website. I would ask that you please bear with us because this is one of our first few webinars. We think it's an exciting new thing that we're offering, but we're still sort of learning the ropes here. So thank you very much, everyone, for joining us. We'll go ahead and get started. I wanted to give a little bit of information about the Foundation for Sarcoidosis Research before we get going. The Foundation obviously is focused on, as our name states, funding sarcoidosis research. We offer an annual award, hang on. It looks like I lost the, okay. We offer an annual research award in partnership with the American Thoracic Society. Since our founding in the year 2000, we have funded nearly $1 million in sarcoidosis-specific research. There are a couple of the smiling faces of our researchers that we funded in the last few years. Dr. Lobelia Samavati from Wayne State University received a grant from us in 2009, and Dr. Kira Oswald-Richter from Vanderbilt University received a grant from us last year. These are 2-year grants, but we award one every year. So Dr. Richter is continuing with her research for this current year, and then we are getting ready to award another researcher for 2011. We also offer educational conferences. This year we're planning our 3rd conference. In 2009 we were in Charleston. Last year we had more than 150 patients in Chicago, Illinois, where we are headquartered. We had patients from 21 states and Canada for a day-long conference. This year in 2011, on November 5th, we will be having a half-day conference in New York City. That conference will be planned in partnership with the Mount Sinai Medical Center, and specifically the Dr. Tierstein support group that meets at Mount Sinai. So information will be available on our website shortly on that conference in New York on November 5th. We also, as many of you know, obviously we offer webinars, and like I mentioned, this is our 3rd one this year. We also have educational booklets available that they're available for purchase in bulk from our website. We will be uploading many of them in a PDF form shortly, and the Education Committee of the Foundation for Sarcoidosis Research has indicated that in 2011, 2012, they would really like to work on a new booklet, which will be Sarcoidosis and the Eye. The Foundation also offers a number of opportunities for support. We have our online support community which is, you can link to it through our website. There are more than 9,000 members as a part of the Inspire online support community. It's a free group. There are people from all 50 states, and I think at last count it was more than 80 countries around the world. And it's a great, vibrant group, good place to ask questions and learn from other people's experiences. And there's that graphic is a screenshot of our website with an arrow to a little button that you can get to join that. There are also support groups all around the country. They are led by a fabulously vibrant group of women. Well, I guess women and one man who make up our support group advisory council. The advisory council meets monthly and provides different resources and ideas for support groups around the country. The support group advisory council was instrumental in planning the Sarcoidosis Awareness Month last April, and they are also in the process of updating the manual for people who are interested in starting support groups, as well as a listing of the support groups that we keep on our website. Also, many people call us about, wondering about different ways that they can raise awareness of sarcoidosis. It's very common that people get frustrated because, sarcoidosis is not something you hear about in the general mainstream media or in day-to-day life. And we do have these awareness-raising tools on our website. We have a new T-shirt which will be available on our website very shortly. Those will be $15, and then of course we have the wristbands that everybody likes so much. Those are available on our website as well. And finally, before I turn the reins over to Dr. Stern, I just want to thank everybody on the call for participating and also for your support. The foundation would not be able to do any of the things that we do, fund research, provide education, plan conferences, distribute booklets, that sort of thing, without the generous support of patients and other family members around the country. It is not uncommon for us to receive donations of, $5, $10, $21.60 was a donation we received recently, and that's because I understand that in the current economic times, people have obviously limitations to how much they can give, but it's heartwarming and it's very gratifying to know that people count us as one of the causes that they care deeply about and are willing to support us with a donation. So thank you, everyone, for participating, and thank you for your support. Finally, without further ado, I want to introduce Dr. Barney Stern. He is with the University of Maryland as a professor of neurology. Dr. Stern has been a friend of the Foundation's for quite a few years, but has been interested in neurosarcoidosis for quite a bit of time, more than 3 decades, he says, which is just about 3 times older than the Foundation itself. So he's quite the expert on the topic, and we're very pleased to have him join us and present this information. Before I hand the reins over to him, I want to share a bit of housekeeping. As I mentioned before I started, everybody's line is on mute. If during the topic you have questions, feel free to there should be a question box on your control panel there, and just type your question in and click send privately. Andrea Wilson, who is the founder of the Foundation for Sarcoidosis Research and the president of the organization, is also on the call with us, and she and I will be scrolling through the questions and moderating the question and answer time. We will do our best to ask as many of the questions as we possibly can throughout at the conclusion of the program. And if I could also put in a suggestion that people try to you have a question, please try to make it as general as possible so that it's appropriate for all of the people on the call, not just, you know, your particular situation. Dr. Stern obviously is not able to provide specific medical recommendations in his role as presenter of this webinar. So thank you for your consideration on that, and I will, at this point, turn the reins over to Dr. Stern. And there we go. Dr. Stern.
Well, thank you, Julie, and let me say hello to everyone participating in this webinar, and in particular those of you who I've had the pleasure to meet personally over the years. I will try to advance the slides. Julie, you may have to advance it. And Julie?
Okay, let's see. Try one more time, and then I'll... Nope, it looks like I will be the advancer.
You're the advancer.
Okay.
So neurosarcoidosis affects somewhere between 5 and 10% of patients who have sarcoidosis. Sarcoid can impact the central nervous system, meaning the brain and spinal cord, or the peripheral nervous system, meaning peripheral nerves going out to your arms and legs, or the muscles in your body. Next. Sarcoidosis is an inflammatory disorder, and as can be seen on this slide of various specimens of human tissue, there is an aggregation or concentration of inflammatory cells, oftentimes around blood vessels such as small microscopic veins. And this inflammatory process can lead to various damaging effects on whichever part of the body these inflammatory changes impact. So typically this could impact the lungs or the eyes, skin, lymph nodes. But the topic today is how these inflammatory changes can impact the nervous system. Next. There are many clinical presentations of sarcoidosis, and these are listed here in admittedly medical terminology, but I'll walk you through these briefly. Under cranial neuropathies, that means involvement of the nerves that leave the brain and go to various structures about the head and neck. By far the most common cause of
Sorry about that.
By far the most common neurologic involvement from sarcoidosis is what is called a facial palsy or weakness on one side of the face. And fortunately, this tends to get better over time. It could affect one side of the face, both sides of the face, or one side sequentially over time. However, of the 12 cranial nerves, the two that are most troublesome for patients with sarcoidosis is the optic nerve, which involves sight or vision, and the eighth nerve, which involves hearing and sense of dizziness and balance. So that involvement of these cranial nerves, especially the two that I mentioned, can be quite debilitating at times. By meningeal disease, we mean the lining that surrounds the brain and spinal cord, and sometimes you can get inflammation of this structure, and it causes a headache and stiff neck, sensitivity to light, and typically is fairly discrete in how long it will be symptomatic. At other times, those inflammatory cells that I showed you a moment ago can sort of aggregate or coalesce into a large mass lesion that can look like a tumor sitting outside the brain but adjacent to it. The inflammatory cells can also at times cause a blockage of the fluid that is within the brain and around the brain called the cerebral spinal fluid. And this hydrocephalus can cause increased pressure within the head and spinal canal, leading to headache, confusion, nausea, vomiting, etc. The brain can be involved. Most commonly, there are disorders of the hormone system. So patients may have too little thyroid hormone. If it's a woman, there may be disturbances in their menstrual cycle. And if it's a man, there's loss of testosterone and therefore problems with sexual functioning. Sometimes these inflammatory cells can again aggregate as a tumor-like mass in the brain or spinal canal. And at times they spread out, if you will, throughout a portion of the brain, causing confusion and potentially other problems depending where in the brain the inflammatory process is taking place. Because the brain is involved and these inflammatory processes irritate the brain, one can have seizures. And occasionally, the large blood vessels going to the brain become inflamed or compressed by a mass lesion, leading to a stroke. By vegetative dysfunction, what is meant is that a part of the brain called the hypothalamus, which is at the base of the brain, can become involved in the inflammation, and this can lead to disturbances in thirst, in salt regulation, in sleepiness, in weight gain, in appetite control. There can be disease of the spinal cord as it curses up and down your back, and at the bottom of the spinal cord, there are a whole bunch of nerves that leave that help regulate control of your legs, your bladder, and your bowel functioning, and these can at times be involved. The nerves that go out into your arms and legs can be involved, and you can get loss of sensation, weakness, or loss of both sensation and weakness, and sometimes pain can also occur. And finally, the inflammatory process can involve the muscles in your body, causing weakness, sometimes nodules or aggregations of these inflammatory cells, and ultimately a generalized weakness and loss of muscle bulk because of chronic disease. Next, please. So sometimes physicians forget to ask patients about certain key symptoms that, in fact, are very troublesome to them. So disorders of menses, of libido, sexual functioning. In women, galactorrhea or fluid release from the breast when you're not breastfeeding, and trouble with erectile dysfunction. Patients can have excessive thirst from a variety of reasons in sarcoidosis, and there could be altered body temperature, sleep, and appetite. And finally, there is several hormone systems, as indicated here, that can cause problems with your energy level, your weight control, sexual functioning, and response to stress in the sense of response to a surgical procedure or a traumatic accident that requires trauma surgery, let's say from a motor vehicle accident. So there are several issues that are not perhaps traditionally thought of as neurologic symptoms that really can be impacted by neurologic involvement by sarcoidosis. Next. Oh, I just did that. Let's see. So I'm going to try to move my cursor here, but this is an MRI scan, and there are areas of inflammation right through here and coming down in the middle and then over here. And these areas represent areas of inflammation along the meninges or surface of the brain that represent inflammation from sarcoidosis. Here is a representation of the spinal cord. The brain is up here, and you can see these areas of inflammation along the surface of the spinal cord, again suggesting inflammation and potential disruption of normal spinal cord functioning. So the bottom line here is that modern imaging with MRI is exquisitely helpful and in guiding the findings on a patient and helping to monitor the patient's response to treatment. There are many conditions that have to be considered that can masquerade as sarcoidosis. And this is an exhaustive list, but not a total list. But what it's really telling you is that when a physician approaches a patient with sarcoidosis, he or she needs to consider many other conditions, and that's why it's so important, when possible, to get pathologic specimens to prove that the patient indeed has sarcoidosis and not an alternate diagnosis, so that much effort is often put into finding out is there involvement of a lymph node or the lung, and occasionally nervous tissue is also biopsied, although that's much more difficult and we try to avoid it. But just to highlight a couple of these conditions, MS or multiple sclerosis can masquerade as sarcoid. SLE or lupus that you've heard of is something to consider. Lyme disease is a consideration. HIV infection at times one has to consider, and malignancies such as lymphoma. So I won't go through all of these other than to say that it's very important to make sure we're not dealing with a treatable infection or that we're dealing with some other diagnosis which requires very different treatment than we might for sarcoid, and which offers the patient a very different prognosis, either better or worse than the diagnosis of neurosarcoidosis. So in line with keeping the importance of diagnosis out in front, I have used the approach of stipulating, does this patient have possible sarcoid, probable sarcoid, or definite sarcoid? And that helps keep us honest, I think, in the sense that if a patient looks like they have definite sarcoid, then we could be pretty sure about what we're talking about. But if it's possible or probable, we really have to keep our eyes open as to could we be missing a diagnosis, and we always have to think, could the patient have some other condition? Finally, as I'll state later again, it's very important that should another problem develop in a patient, you have to be very open to saying, could some new problem be occurring? So fortunately, about 2/3 of patients have a single course of involvement neurologically. These patients typically have facial weakness or an aseptic meningitis and get better and hopefully are not bothered again by neurologic problems. Excuse me. But about 1/3 of patients have progressive disease or a disease that comes and goes, and this typically involves patients who have inflammation of the brain itself, hydrocephalus, the problem with circulation of spinal fluid, or involvement of the optic or eighth nerve that I spoke about earlier. Often patients with severe peripheral neuropathies are in this category, as well as patients who have involvement of muscle. And it's these kind of patients that tend to require a lot of expertise and ongoing care to hopefully optimize their clinical course. So in a typical patient with a facial nerve palsy or an aseptic meningitis, the typical treatment is steroids such as prednisone, a week and then slow tapering over several weeks. And sometimes you require a bit more treatment, but typically these patients do well with some steroid dosing. When we talk about other treatments for patients with progressive disease or so-called remitting relapsing disease, we all have to be aware that there are no rigorous studies that have defined optimal treatment. There is no FDA-approved drug for sarcoidosis. And for neurologic disease, there simply are not enough patients around the country to ask patients to be randomized with 400 patients in Group A, 400 patients in Group B, and compare treatment in Group A with Group B. It's something we would like to do because we would be much more scientifically sure of any statements that we offer to patients. But the reality is we're left with so-called case theories. How did this group of 12 patients go? And then so-called expert opinion as to folks who have had the privilege of treating this condition over the years, what has been their experience given the patient's situation and how might that be addressed. My own bias is that treatment decisions should be guided by the anticipated patient's clinical course and sort of the natural history of what we expect with, given the patient's clinical manifestations, as I've just discussed, and also be aware of what adverse treatment effects can occur and how that might impact already involved organs that the patient is sort of bringing to the bedside. So if we're just talking about hydrocephalus and ventricular enlargement, if it's asymptomatic, we may just observe the patient. If it's very mild enlargement and maybe a mild headache, steroid therapy might be totally sufficient. If it's severe enlargement with life-threatening blockage and it's not being relieved with steroids, you may have to place, through a surgical procedure, a shunt or a drain to drain off the fluid from the brain and head to relieve the pressure. And then one also has to treat with steroids and perhaps other medications. Unfortunately, and it's something we have to be very well aware of, that even in a patient who does not have very large ventricle, there can be a rapid neurologic deterioration that could occur spontaneously or after a lumbar puncture. And so this is something that has to be watched for very, very carefully. When we think about putting in a shunt or not putting in a shunt, which is sort of a plastic drainage tube, if you will, that shunt may become obstructed from the actual inflammation of the sarcoid, and it may also fail to drain the whole lake, if you will, because the inflammatory process can sort of cause the lake to be subdivided into ponds, if you will. And so one shunt may not be enough. Sometimes several shunts have to be placed. Also, you're putting a foreign object in a patient who, by virtue of steroids or other medications, has diminished resistance to infection, and therefore there's always the risk of causing an infection, which can be very serious. So I think it's important to educate patients and caregivers when to seek emergent care. And one way of helping patients and caregivers is having the patient have a copy of their CT or MRI scan, which shows the ventricular size. So if they go to an emergency department where otherwise no records are available, the folks in the emergency department have a reference point as to what the brain looked like 2 weeks, 2 months, or 6 months earlier. So what about brain disease itself? So we spoke about so-called vegetative symptoms like hormone deficiencies or increased sleepiness. And rarely does treatment actually with immunosuppression improve these kind of symptoms. Occasionally it happens, but not all the time. And then seizures can occur, as I mentioned earlier, but that seizure control is usually correlated with the underlying inflammatory disease and how well that's controlled or not controlled. In terms of severe disease, prednisone, as I said, is the initial dose that many of us use. A key here is slow tapering of the prednisone dose. And as you get to lower doses, somewhere around 10 milligrams a day, in some patients it's 15, in some patients it's 7.5, you really have to anticipate an exacerbation, and it's worthwhile to reevaluate the patient for ongoing disease activity and sort of define the baseline dosage for the individual patient. As one goes below 10 milligrams a day, I tend to taper even slower because I want to not allow the disease to get ahead of the tapering regimen, so to speak. And I want to know if things are getting worse for the patient as the dose goes down. And then oftentimes, if there is a relapse in symptoms, you can double the dose and sort of quiet down the disease again. If there's an acute severe disease, intravenous high-dose steroids can be used. And more recently, Infliximab can be used. Now, I showed you early on those cells that were part of the inflammatory process, and those cells secrete, if you will, various inflammatory proteins. And one of those proteins is called TNF-alpha, which stands for tumor necrosis factor alpha. And that's a historic nomenclature, but TNF is thought to play a key role in the inflammatory process. And we now have so-called monoclonal antibodies, of which Infliximab is one, which is a antibody that blocks the actions of TNF. And so this is another way of trying nowadays to decrease the inflammatory process, and it's often used in association with other immunosuppressive strategies. So again, when one thinks about other treatments, case reports, expert opinion, the indications to me are the need to avoid steroids as an initial therapy, such that, let's say, the patient is severely diabetic. If there are adverse steroid effects, such as severe thinning of the bones or osteoporosis, or there's ongoing disease activity in spite of aggressive therapy. Now, more recently, we've started using these alternate or adjunct therapies earlier on to try to avoid steroid side effects in the first place in those patients who we anticipate a prolonged need for immunosuppression. Rarely are we able to completely withdraw steroid therapy with alternate or adjunct treatments, but oftentimes we can decrease the dose considerably, thereby decreasing some of the very troublesome side effects of chronic steroid therapy. So there are a whole list of these medications which I'll leave for you to look at. None of these medications have been compared one to another. Their use is really based on expert opinion, familiarity. The need to avoid a drug that has an adverse potential effect on a part of the body that's already been compromised by sarcoid. So let's say your liver is involved in sarcoid. You may want to use a drug that does not typically cause liver problems. So again, this is a list of drugs that is available. And more recently, we've gone to drugs that also seem to have an impact on the immune system in a more selective way or a more novel way. And again, these monoclonal antibodies to TNF-alpha, and the ones that we commonly use are Infliximab and adalimumab, if you can pronounce that. Occasionally, for central nervous system disease, radiation therapy is used. So it's important to take care of the whole patient. It's important to think about exercise training, dietary programs for weight gain and adequate nutrition, adequate protein intake, appropriate rehabilitation strategies, treatment of depression, hormone replacement therapy, especially for low thyroid hormone or low testosterone or low estrogen. Stress corticosteroids, meaning if you're on a very low dose of prednisone for a long time and need a gallbladder operation, you may need some intravenous steroids around the time of that surgery. Continuing to follow up for osteoporosis and really trying to treat the fatigue, which may be related to inflammatory proteins in your body, addressing that with exercise program, treating depression and obesity, hormone treatments, treating sleep disorders, which are quite common, and occasionally using medications to help combat fatigue. One has to be concerned about long-term complications, and here I'm referring to neurologic complications only, but there are some very specific long-term complications that we have to be aware of in treating patients with sarcoidosis and its consequential immunosuppressed state. So one of my thoughts that I always consider in patients, if a patient is not doing well, the diagnosis of sarcoidosis should be questioned, alternate causes investigated, and a search for other complications begun. One should be very careful not to attribute the patient's deterioration to sarcoidosis and just automatically increase the intensity of immunosuppression. So we're all interested in research, and research in sarcoidosis, in neurosarcoidosis, has been very challenging. There are many neurologic manifestations, and I tend to think about this as targeting key clinical findings such as vision, hearing, timed walk, cognitive testing. Using the MRI scan or let's say nerve conduction studies to provide objective measures of inflammation or nerve dysfunction, and thinking about using some of the functional scales that are used in multiple sclerosis or Parkinson's disease research to give us a more global measure of how a patient is doing. It was also necessary to measure fatigue and depression in patients within a research setting as well as a clinical setting. There are many challenges in research. We have a rare disease that we're talking about today that could be classified as an orphan disease. There are very few physicians nationwide who have a real interest in this disease and expertise. There's a lack of funding for research. It's such a small slice of the whole medical universe. It's difficult to get federal funding. You've heard today about the good work that the foundation here is doing for research and the potential for grateful patients. So what is needed for next steps in neurosarcoidosis research? A dedicated nurse to really be a resource for patients nationwide. An internet-based research website. Ideally, a biologic sample repository where samples of spinal fluid or blood or even brain tissue could be frozen and used for research. And establishing collaboration with laboratory-based scientists as well as clinical researchers. So that's my presentation. I'll leave the last slide up and be happy to try to answer your questions. Thank you.
Okay, well, thank you, Dr. Stern. This is Andrea Wilson, and I want to thank everybody for being with us. I think you've done such a good job in explaining everything that we do not have a ton of questions. I do think, well, there is one question that has been asked a few times, a few different ways. which is how is neurosarcoidosis diagnosed? I know that that is sort of a tricky question.
Well, I think there are a few ways of approaching this. If a patient has known sarcoidosis, let's say involving the lungs and eyes, has biopsy evidence of lung disease, and then develops a neurologic problem, I think one way of approaching it is, first of all, saying, is the neurologic problem something that we see as a neurologic complication of sarcoid? And if it looks like it could be, then one goes through a series of steps to say, what is the likelihood based on typically imaging with MR scanning, potentially a spinal fluid test to try to eliminate the possibility of infection or tumor masquerading as sarcoid. And if it looks like this could be sarcoid, then it might fall into that probable category and be treated as such. The key here is that if the patient does not respond fairly rapidly and typically to treatment, then you have to step back and say, maybe this isn't sarcoid. What's more challenging is if a patient presents with a neurologic problem and has no known illness otherwise, then you have to start and go back, if you will, to that long list I showed several slides ago and say, what might on this, what could sarcoid be represented here, and then go through the process, if you will, of trying to demonstrate inflammation in some other part of the body, in the lungs, in the eyes, in the lymph nodes, because that's where we know sarcoid typically impacts, and it's typically a so-called multisystemic disease. But sometimes we can't find any evidence systemically, and that's probably in maybe 5 to 10% of patients. And then ultimately we may, if it's involving the brain, have to resort to actual biopsy of the brain. But that sounds very scary. In effect, it's done very carefully, as you might assume, and really with relative safety. The biggest challenge in this circumstance is that treatment is begun before a diagnosis is achieved. And in those cases, sometimes it becomes very, very difficult to arrive at a conclusive diagnosis.
Okay. Okay. Thank you. Then this other one is sort of a two-part question. Kim would like you to explain what the rapid deterioration symptoms after an LP neurologically and within occur, and within what time frame they usually do occur.
Okay. I think we have to distinguish here between an LP that is done in a patient with hydrocephalus or enlargement of the ventricles and a LP done in patients who do not have that situation.
Okay.
And I want to make it very clear that I'm only talking about a sudden deterioration in those patients which have significant enlargement of the ventricles or fluid-containing parts of the brain. And that's a very small group of patients with neurosarcoids. And in those patients, sometimes, not inevitably, not all the time, if a lumbar puncture is done, that within minutes or an hour or so, a patient can become drowsy, confused, nausea, vomiting, sleepy, those kind of things. That is very, very different than the kind of complications that can occur in a patient following a routine diagnostic lumbar puncture, in which patients may get some local back pain, they may get some pain going down a leg if a nerve is irritated from the needle, and sometimes they get what's called a post-LP headache or a low-volume headache, and this is a headache where the patient feels good when they're lying down, but develops a headache when upright, when standing. That's a very different set of complications than what I was referring to. And I don't mean to alarm anyone on this call. It's important to remember your doctor may suggest a lumbar puncture, and that's part of good medical care in terms of trying to make sure there's no infection, there's no tumor, there are no other alternate diagnoses. And it's only in this very, very unusual circumstance, but given its seriousness, that's why I mentioned it.
Okay. The second part of this question was, could a lumbar puncture open a gateway in a known sarcoidosis, sarcoidosis-proven patient to allow sarcoid to enter the system, the nervous system?
That's a very interesting question. I have never seen anything to that effect, and I've never, in my own practice, have never seen anything like that as a connection. I think it's important to remember that probably whatever starts the process in the nervous system is probably getting there, if you will, through some blood-borne inflammatory process, and is not, if you will, being dragged in from the outside. So I would say that is not something one should be concerned about.
Okay. Are epidural injections good treatments in general for spinal neurosarc, or spinal inflammation, excuse me?
So are epidural steroid injections helpful?
Yes.
My own bias is that they may deliver steroids to too limited an area, and usually the inflammation is fairly widespread, so I think you're probably better off with a systemic administration of the drug. Remember that what you see on MRI scan is probably the tip of the iceberg. The MRI scan is not a microscope. It's showing you the areas where the inflammation is intense enough to, if you will, be evident on imaging. But just because you don't see that sort of brightening when contrast is administered does not mean that there's no inflammation, if you will, 2 inches away from a site of enhancement or brightening. So my bias is to go more with systemic medications because in all probability the disease is more widespread than is evident by imaging.
Okay.
Very good question.
Okay. And is IVIG used as a common treatment? One person wants to know.
Someone's up on the literature. So there are a few case reports now of IVIG for sarcoidosis, and especially for peripheral neuropathy and sarcoidosis. The IVIG has been used for a decade or more for a variety of immunological disorders and for various neurologic disorders that affect the peripheral nerves and muscle. In terms of IVIG for central nervous system disease, I personally have not seen robust literature to that effect. There's an emerging literature for IVIG for so-called small fiber sensory neuropathy and perhaps also autonomic neuropathy. And that's a very interesting possibility. But again, like all of these treatments, unproven scientifically, does have potential side effects that have to be taken into consideration based on the patient's individual health issues. And so I would sort of put it as part of the list, but I don't think at this point we could put it at the top, the middle, or the bottom of the list.
Okay. Nancy wants to know if spinal synovial cysts can be related to neurosarcoid. Spinal
synovial cysts, I doubt are related to sarcoid per se. I think they're probably more developmental or post-traumatic. That's somewhat different. You know, I mentioned earlier that, let's say in the ventricles, you can get inflammation and little dams or compartments can form on a larger lake. But I can't say I've ever seen a synovial cyst as something related to sarcoid per se.
Okay. Another one, I'm sorry, I'm having to read this from the computer monitor here. How often does CNS sarcoid progress to peripheral nerves even when under immunosuppressant therapy? That becomes evident as weaning from medication occurs.
So one of the things that tends to occur in patients, and this is not a ironclad rule, but the disease tends to stay true to its presentation. So let's say the initial presentation is in the spinal cord. It's rare that suddenly it might jump to the muscles, or if it started in the peripheral nerves, that suddenly it jumps to the brain. That's not to say it can't happen, but most of the time, if it, let's say, starting in the brain, it tends to remain in the brain. The questioner is absolutely correct that as you come down on the dose, you can get of immunosuppressive drugs. You can get worsening of the disease. It tends to get worse in the way in which it initially presented, but it's as the dose becomes very low, or perhaps even as you get off medication, then it could come up somewhere else, but it tends not to. So that's a wishy-washy answer, but it's the best I could do.
Okay. And then Karen Reynolds wanted to know if there were copies of the presentations of the webinar, and those will be available on the website, assuming this is all recorded. We hope that the technology is cooperating with us. And then I think we have time for one more. Is there a liver-sparing treatment that you recommend?
That tends to be pretty specific patient-oriented question, because it really depends on what the presumptive neurologic manifestations are, how severe they are. Is it in the peripheral nervous system? Is it the central nervous system? So if there's liver involvement, one might want to avoid a drug such as methotrexate. One might want to explore a TNF monoclonal antibody like Infliximab, or a drug like mycophenolate, which, although we monitor liver tests, tends not to really impact the liver very much. The other point I would just make is that sometimes you're in a bind, and as your audience probably knows, sarcoidosis can affect the liver. So then you have to say, well, here's a drug that may impact the liver, but it may also make the liver better by treatment. And so you may start on treating with a drug that potentially has liver side effects, and carefully watch your blood tests concerning the liver. And if the blood tests are getting better, then you're treating the inflammation. If the blood tests are getting worse, then you're adding side effects to the medication to the already inflamed liver. So it's a question that is very appropriate, little hard to answer accurately without knowing real specifics of the questioner, which we can't do on this webinar.
Right. Okay. Well, thank you very much for sharing your wisdom, and thank you, everybody, for being with us. We really appreciate it. And I'm sorry that we were not able to get to everybody's questions. We tried to get through as many as possible, but I think with our time constraints, hopefully everybody will understand that. So thank you so much, and be well, and we will look forward to talking to most of you at some point soon.
Bye-bye.
Bye-bye.
Thank you, everyone.